Well, hello there, and welcome to this presentation on the anti-inflammatory and anti-gout drugs. This is Professor White. To start off our conversation on anti-inflammatory medications and anti-gout really, we do need to discuss what inflammation is. So the textbook says that inflammation is a localized protective response which is stimulated by injury to the tissues. Basically, it's an attempt of the body to wall off and repair the injured area. So the signs and symptoms of inflammation are pain, fever, loss of function, redness, and swelling. The reason that our body has this protective response is to allow for capillary permeability to increase to allow things like macrophages, neutrophils to get into the site of injury. So that's why we see the redness and the swelling, the erythema as it gets warm. So again, it's our body's protective nature to be able to guard against injury and invasion. One of the problems with inflammation, though, is when we have either too much inflammation or the patient is experiencing pain and discomfort. So that's when we start to look at our different classes of medications to treat inflammation. The large class that we need to focus on for the moment are called NSAIDs, or are non-steroidal anti-inflammatory drugs. As the name implies, these are not steroids and they work against inflammation. So it's a bunch of different meds. It's a pretty large group, and all of the NSAIDs have the same properties, right? They are all analgesics, meaning they help with pain. They're anti-inflammatory, means they decrease their inflammation, and antipyretic, which means they work against fevers and elevated temperatures. Aspirin is the only one in that class, however, that also has platelet inhibition, so it's a little bit different. Some other indications for NSAIDs for you to be aware of, and I think most of us know this just on a sort of just being humans in our country, that we're constantly popping, acetaminophen and Motrin or ibuprofen. So headaches, muscle aches, arthritic pain after surgery, a lot of arthritic disorders, and gout and high uric acid levels. So let's talk about how these work. So NSAIDs as a general class, they inhibit prostaglandins or leukotrienes. So these are both implicated in the inflammation and the pain response. The other thing to be aware of with our NSAIDs is the COX enzyme. So there are two enzymes, COX-1 and COX-2. And what COX-1 does is it maintains our GI mucosa. So this is what prevents us from having the stomach acid sort of rip through our stomachs, is the gastric mucosa. So COX-1 absolutely helps us maintain that. COX-2, on the other hand, is in that it's an enzyme that actually leads into more inflammation. It's part of the inflammation pathway. And so with the development of these drugs, we have these COX inhibitors and these non-steroidal anti-inflammatories. Basically, they're non-selective for COX, which means that they inhibit COX-1 and COX-2. And we can talk about this a little bit later as to the development of the COX-2 inhibitors. But for now, just understand that there's a couple different enzymes, and because the NSAIDs work on those enzymes, those are the side effects that we'll see. In fact, let's talk about it real briefly here. Our NSAIDs have the ability to cause gastric ulcers because of inhibiting COX-1. So remember, if COX-1 maintains the GI lining, inhibiting it can cause ulcers, bleeding. So let's look at some of the contraindications to this medication. So remember, an allergy to a medication is a contraindication. Anybody that has a documented aspirin allergy, to remember that that is an NSAID, so they should not be receiving any NSAIDs. And any condition that would put the patient at risk for bleeding. So some of the ones that I have listed here are vitamin K deficiency, So remember, vitamin K is needed for the coagulation cascade, and those with peptic ulcer disease. So they've already got a problem with their stomach lining. The adverse effects, some of the most important ones, of course, and most common would be heartburn and GI bleeding. But there are some others as well. So NSAIDs can cause renal failure. They can cause pulmonary edema. They can put the patient at increased risk for heart attack and stroke. They can alter hemostasis. Remember, hemostasis is a word that means stopping the bleed. It's how we keep the blood in the vessels. Liver toxicity, skin issues, and tinnitus and hearing loss, specifically as a toxicity for adults. There are numerous interactions. Some of the most important for us to remember are that NSAIDs can cause increased bleeding because of how the platelets may be inhibited, and also if we have decreased clotting ability. Any NSAID that's taken with a diuretic can cause reduced diuretic and hypotensive effects. NSAIDs taken with steroids can cause increased ulcer formation. A brief look at renal function. So remember that our kidneys actually rely on prostaglandins to function effectively, and NSAIDs impair that, so they can cause acute or chronic kidney injury and failure. And if our patient is dehydrated, has heart failure, liver issues, ACE inhibitors on diuretics, we can cause increased renal toxicity. When we spoke earlier about the increase of strokes and heart attacks, remember that's true for everyone but aspirin, because aspirin is actually got a different sort of piece to it, and that it's an antiplatelet. So there is a black box warning about strokes and heart attacks, and about taking an NSAID along with aspirin can sort of interrupt the protective aspect of the aspirin. So this picture that I have right here for you is the actual black box warning that is found on NSAIDs. Take a moment and read it, and you can see that it's a pretty important deal. All right, so we're going to take a deep dive into some of the NSAIDs at this point. The first one we're going to talk about today is aspirin. It's often called ASA or written as ASA. So some of the cool things about aspirin is that it is shown to enhance survival after a heart attack. We do give it at the first sign of a heart attack. It is irreversible inhibitor of COX-1. So remember, we're COX-1. That was what protects the stomach lining and also inhibits within the platelets themselves. So it promotes, I guess, blood thinning. It's not a blood thinner, so don't let me misspeak on that. Basically, it prevents platelet aggregation, so it doesn't allow them to stick together. And when you take this medication, it is for the life of the platelet. So remember, other NSAIDs do not have that effect. This is why we tell patients who are on aspirin to hold their aspirin prior to surgery, because the platelets that were affected by when they took the aspirin, they will be like that for the life of the platelet. Some of the other uses that aspirin has, of course, for mild pain and lupus, because it does have some anti-rheumatic effects, and also for elevated temperature. Let's look at the dosing real quick. When you're preparing medications for patients, these are generally the 3 types of aspirin that you'll see. Now, their colors may vary a little bit, things like that, but these are basically what you get. So the daily dose, it can be either 81 milligrams or 325. That's for cardio prevention, so stroke and heart attack prevention in at-risk people. And they do seem to be pretty beneficial. Doesn't matter the dose, whether it's 81 milligrams or 325 milligrams for venous thromboembolism prevention. I have on here 3 little pictures. So the one is an aspirin tablet. This is just an uncoated 325 milligram aspirin tablet. Next to it is an 81 milligram chewable tablet. Remember, if somebody's having a heart attack, that's the one we want to give them, because if it's chewed, it gets to work right away. And then because of the effects on the stomach, we do have an enteric-coated aspirin, which many folks may be on. Remember, enteric-coated would not be for acute treatment of a heart attack, and that's because of the pharmacokinetics of the absorption. This slide here is to remind you about Ray's syndrome. So Ray's syndrome is a potentially life-threatening condition in which a child develops neurological deficits that can lead to coma and also liver damage. And it's triggered by a viral illness and also by the aspirin therapy itself in the presence of a viral illness. So this is why, in general, we don't give aspirin to children if they potentially could have a viral illness. It's a good idea just to avoid it in general. The problem here is that if the child survives, they may end up with permanent neurological damage. So that's why, again, aspirin is contraindicated in children with flu-like symptoms. But it's also not 100% safe for anyone. So we can become toxic. Too much aspirin. And we can test for aspirin levels in the blood, not routinely done, just in case we had suspected that a patient might have salicylate toxicity. So the most common manifestations of intoxication in the children would be hyperventilation and those central nervous system effects that you see, like being drowsy and dizzy and behavioral changes. In adults, the biggest sign and symptom that we're going to see is actually going to be tinnitus and hearing loss. So we're always on the lookout for that. All right, let's take a look at one of the other meds in the NSAID class. Indomethacin. So this works for pain, inflammation, rheumatic diseases, and also has antipyretic effects, so it will bring down a fever. This is not one that you can just go get over the counter. This is a prescription one. We use it a lot with folks with rheumatoid arthritis, ankylosing spondylitis, a lot of different sort of autoimmune conditions. It's also used to treat preterm labor. It is available oral, rectal, and IV. So remember, it's an anti-inflammatory. So if we're giving it for what this section is about, it should cause a reduction in their pain response. Toradol sits in the anti-inflammatory family as well as ketorolac. This medication, it is available by mouth. It's available sublingual. It's available in an eye drop. It's available intravenous. It can be given sub-Q or IM. So it doesn't have as much anti-inflammatory activity, but it has a lot more analgesic activity and works really well for patients who are in need of adjunct pain control. So we will use this. It is, when it's prescribed, it's no more than 5 days for moderate to severe acute pain. Big problems with it is the renal impairment, GI, nausea, dyspepsia. So I put a couple of different things up here to show you. I have like a regular vial of ketorolac. That's the normal adult dose by IV would be anywhere from 15 to 30 milligrams. And then I have some ketorolac eye drops as well. It has another one in it, but that would be the anti-inflammatory eye drops that we would use on patients after cataract surgery. So that's just one of them. Quick little slide for you guys on ibuprofen and naproxen. So these are known by trade names as Motrin and Advil, and naproxen is Aleve. So ibuprofen is the most used NSAID out there. It is used for all sorts of different reasons, as you know. Some people believe that this works better for them than others, and they may actually be right because some people have their bodies, the pharmacokinetics are just different. And then there's naproxen. That's the second most used after ibuprofen. This actually has a better effect, like adverse effect profile than ibuprofen and fewer drug interactions with our ACE inhibitors. But remember, both of these can cause GI bleeding, and we always want to be on the lookout for that with our patients who are taking these, especially if they're taking them frequently. The other thing that I know just from personal use and taking care of patients for so many years is that as people are taking these, especially for headaches and things like that, that they end up getting rebound headaches. So they really shouldn't be taking them all the time. All right, celecoxib or Celebrex. This is the one that you'll see on the TV, or maybe not anymore. Maybe I'm so old that it's they're not playing these commercials anymore. But they used to say celebrate with Celebrex, and that little picture there is right from their TV spot. Basically, if you take their pill, you could suddenly take up dancing and feel better. So this class of drugs, it is a COX-2 inhibitor. Remember, we spoke about in the beginning about COX-1 and COX-2. So this one is selective for COX-2. These were developed to try and get around the GI effects of the NSAIDs. Unfortunately, as a class of medications, all of them were pulled off the market except for this one, because what it did is it caused record numbers of cardio events, strokes and heart attacks, so thrombo events. So they were taken off the market. So again, not too much effect on the platelets, and it cannot be used in patients with a known sulfa allergy, so celecoxib or Celebrex. The next condition that we have is gout. So gout is often known as a disease of kings. It's related to purine metabolism and uric acid metabolism. So uric acid would be result of the purine metabolism. But regardless, there's two different ways that we end up with hyperuricemia, or increased uric acid levels in the blood. And one of them is that we have the under excretion of the uric acid, meaning that we have normal amounts of uric acid in the body, but the kidneys are not excreting it, so that causes it to build up. And the other is overproduction of uric acid, meaning the body's just making too much. And that's the one that's really indicating a lot of dietary causes of gout. So what happens is the uric acid crystals, they end up getting deposited in the tissues and the joints, and that results in pain and inflammation and something called prodroga, which is a very, very sore large toe, the hallux, the great toe. The other issue with this uric acid, though, is that it can actually cause crystals to form and precipitate in the kidneys and can prompt kidney failure. All right, as we start to go into the gout busters or the anti-gout drugs, I've listed several of them here. I did put the ones in highlight that you'll see more often than not out in your work as a nurse. Not to say that you wouldn't see the other ones, and we need to know a little bit about them, but the most common ones that you're going to see are allopurinol, colchicine, and probenecid. We also use probenecid for some other things. So first and foremost is allopurinol. That is the prototype drug in the class that it sits in, which is a xanthine oxidase inhibitor. So it is used to prevent uric acid production. That's important because what it does is it prevents the body from making more, but it doesn't get rid of the uric acid that's already in the body. So if you have a person who can't get rid or excrete the uric acid, this will prevent them from making more, but it won't do anything about the uric acid that's already in the system. Some of the side effects are here, the adverse effects. Stevens-Johnson syndrome would be one of the biggest ones. And the other thing for allopurinol, we use it to prevent tumor lysis syndrome. So keep that in your pocket for when you start to learn about cancer and especially leukemias and chemotherapy. And probenecid basically increases the excretion of uric acid. So where allopurinol would keep you from making more, probenecid would force the excretion of it. But it's working on the kidneys, so you must have good kidney function to use this. So the patient must have a good kidney function. I'm just looking at your textbook just to see what it said in here for a brief moment. It says to take it with milk or antacids for a week, and then 500 milligrams twice a day after. So we start at 250, then go to 500. And then we need to monitor our uric acid levels with these medications because that's how we adjust the drugs. That's how we know if they're working or not. Febuxostat is another one of the xanthine oxidase drugs. It is more selective for that than allopurinol, but they think it causes more cardiac risk factors than allopurinol. And honestly, allopurinol is much more widely available and cheaper, so it's used more often. Colchicine is an interesting drug. Colchicine is actually the oldest treatment that we have for acute gout. It's not first line, it's considered second line therapy. Give NSAIDs first, and then colchicine would be appropriate for acute attacks of gout. It is a very, very powerful mitotic inhibitor. So for this reason, it can cause leukopenia. So we prefer it to be used for short-term management of gouty arthritis. However, for some folks, it is used routinely for prophylaxis. When I had patients who had developed gout while I was in the hospital, we, of course, ran a uric acid level. The patient I had was complaining of a lot of pain, and it was pretty textbook. And the provider actually ordered the colchicine. So I give the patient the dose of that, knowing very well that if it is gout, colchicine works pretty quick and would reduce the pain in a matter of hours. And in the case of my dear patient, they had a resolution of their pain. I mean, they still had pain, but it was not so severe. It went from like an 8 or a 9 to a 2 or 3 within just a couple hours. So that's the benefit of colchicine. We do know, however, that colchicine can cause renal effects. It's taken on an empty stomach because it's better absorbed that way. And we need to increase our fluids unless there's some reason to not do that, like a contraindication. You have to be very careful in our patients with renal dysfunction. Lesinurad is another anti-gout medication. This is the only one that sits in the class of the uric acid transporter inhibitor. So basically prevents uric acid reabsorption, and that lowers the uric acid levels. It is not taken alone. It must be given in combination with something like allopurinol. It can cause renal failure and does need to be taken with at least 2 liters of fluid a day. There is some hormonal interactions, and in your textbook it states that all forms of hormonal contraceptives may be less effective during this therapy. So we would want to make sure that our clients, if they are of childbearing age, that they practice another method of birth control. All right, let's take a look at an herbal product, the glucosamine and chondroitin. This is used very frequently out in the community. People use it to treat osteoarthritis and pain. People give it to their dogs. They give it to themselves. So adverse effects are those in the GI tract, and then problems with the glucosamine, which is that it can cause drowsiness, headache, and some skin reactions. And drug interactions enhances the effects of warfarin, right? So it's going to lead to potential increased bleeding in our patients, and also increases insulin resistance, which means that the blood sugars of our patients would be potentially elevated. If that's the case, then they might need higher doses of their medications for diabetes. All right, so let's just look at general NSAID nursing implications, things that you should probably be aware of. Anytime we have a patient that's starting on these, we want to assess their contraindications, especially looking at our risk of GI bleeding, those that have any lesions, any peptic ulcer disease, anybody with bleeding disorders already, whether they would be inherited bleeding disorders or ones caused by medical care. Think about people on blood thinners, warfarin, things of that nature. You want to check the baseline labs, make sure you have those available of your heart functioning, your kidney and liver function, the CBCs and the platelet counts, because remember, we have sometimes problems with platelets with our NSAIDs. A thorough medication history, looking for possible interactions. Don't forget about herbal preparations and supplements. No aspirin for children. That's just good teaching. It's to prevent Ray's syndrome. Will people still use aspirin? Potentially, but it's really not best for the kids. Taking these NSAIDs with food, milk, and antacids can be very helpful. May take up to 3 to 4 weeks of therapy for NSAIDs to be therapeutic as far as what we're using them for, usually pain control. Nursing implications were to make sure we're monitoring for GI bleeding, stools for occult blood, give teaching to your patients to report new or worsening abdominal pain. They should not drink when they're taking NSAIDs. And then look to make sure they're therapeutic, right? What do we want? Decrease in inflammation signs and symptoms, better movement, less tenderness. All right, so as we go in, one of the last meds I want to talk about, I saved it to last because it's not technically an NSAID. But here we go. The medication that I just need to talk to you really quickly about is called misoprostol or Cytotec. We're very familiar with Cytotec in certain circles because it's used to induce delivery of a child. So it's also used to, sort of stimulate childbirth and also for abortive reasons. But at its heart, it wasn't developed for that. It is actually something that inhibits gastric acid secretion. So it's very protective to the stomach for those people who are on long-term NSAIDs, and that's why they would be taking it, right? So basically it's to help prevent ulceration in people taking NSAIDs. But because of the other uses of this drug, it would be worth noting that it should not be used during pregnancy, and also it is passed in breast milk. So in order to be safe when we're taking care of patients that are taking this, we need to make sure that the patient is not pregnant while on therapy and that they use reliable birth control. Okay, so that would be just a couple little tidbits about Cytotec. All right, if you have any questions, I'll be glad to answer them. You can drop them in the chat or you can message me if you're one of my students. But thank you again and have a great day.